All right, let's get started here. Good morning, everyone. I'm Larry Boris, Executive Director of the National Association for Workplace Healthcare. For those who are not familiar with us, NAWHC formerly was the National Association of Worksite Health Centers. We're a nonprofit membership organization for those who are purchasers, suppliers, and providers of on-site, near-site, mobile, and virtual health centers, as well as who will get engaged with direct contracting for medical services. We have educational programs like you've seen this one today, networking roundtables, resources, the largest clearinghouse of information in this area in the nation, and a variety of benchmarking surveys, which we're going to talk about today. Get more information at nawhc.org or our LinkedIn group. Next slide, please. So this is one of several programs that we have upcoming. Next is in January, we join with the World Conference Forum and hosting the On-Site Employee Health and Wellness Center Summit in Las Vegas. Then there's a webinar on ongoing engagement with employer health centers management. The real key is keeping people coming through those doors, and that'll be you'll see in February. And then in April, we have our annual forum on employer managed healthcare, worksite centers, and direct contracting strategies. We hope you can join us for these. Please go to our website to see other programs as we have throughout the year. Next slide. So today's speaker, myself, and then I'm pleased to have Dr. David Zeig, National Director of Clinical Services for Alliant, and David Kite, National Director of Employee Health Centers at Alliant, members of our organization, good friends, national experts, and I will emphasize national, not just for one part of the country. So feel comfortable and confident that the information that we provide today and that you hear from these gentlemen really is reliable, credible, and objective. Next slide. So the roundtable format that we have for our first Monday roundtable is a little bit different than our webinars. We're going to go around and ask everybody to just give us your name, title, and organization. Then there'll be the presentation by our experts. And then at the end of the session, David will call upon each of you for any comments, questions, sharing of experiences, anything you want to say. In addition, this roundtable is being recorded, and the slides and a link to the recording will be made available to everyone who's registered, as well as those who are members of NAWHC. Next slide. So before I move forward, I'm sorry, let's go through and just have everybody identify themselves and their organization, and I'll call you based upon what I see on my listing here. So Amber Rule, would you unmute yourself and give us your name, title, and organization?
Sure. My name is Amber Ruley. I'm the manager of workplace clinics for Freighter Health.
Thank you. And Danielle at Planaba, would you introduce yourself, please?
Hi, good afternoon. I'm Danielle Aplenelp, and I'm a Senior Manager of Healthcare Plans at Indiana University.
Great, thank you. Ella Zofke. Ella, introduce yourself.
Hi, Ella Zofke at Alliant. Title is Associate Consultant, working with David and Dr. Zig.
Thank you. Jeff McGuire. Jeff, introduce yourself, please.
Hi there, I'm Jeff McGuire, Principal Methods Counsel for Tyson Foods.
Great, thank you. John C. Holt. John C., would you introduce yourself, please?
Hi, I'm John C. Holt. I'm the Director of Employee Wellness for Metro Nashville Public Schools.
Thank you. Melanie Small. Melanie, introduce yourself if you would.
Hello, I'm Melanie Small. I am the Director of Workplace Health Services at Intermed in Maine.
Great, thank you. Michaela C. Michaela, if you'd introduce yourself.
Hello, everyone. My name is Michaela Chavez. I am the Privacy Officer and member of the Compliance and Quality Team with Employee Health and Wellbeing at Sandia National Labs.
Great, thank you. Mark Fisher. Mark, if you introduce yourself, please.
Hi, Mark Fisher. I'm a consultant with Alliant.
Thank you. Rachel English. Hey, Rachel, if you'd introduce yourself, please.
Good morning. My name is Rachel English. I am a quality analyst with Sandia Labs Employee Health.
Great, thank you. Tom Joel. Tom, introduce yourself, please.
Yes, Thomas Joe, National Director for Employers for Pfizer.
Great, thank you. Tracy R. Tracy, if you introduce yourself, please.
Tracy Rothenberger, clinical manager at Nordic Private Care in Wisconsin, Indiana, and Ohio.
Great. Thank you all very much. So the survey was conducted between April and June of this year. We had over 108 employers, large and small, of all industries, all sizes, all locations, responding, representing about 466 clinics and over 2 million employees. 50% of the participants had offered their center for over 10 years. And the largest segment of the industry was in manufacturing, followed by healthcare and financial services and government. The average employer size was almost 9,000. But I will tell you, among our NAWHC members, we have some as small as 200 and some that have, of course, more than 7 figures as participants. So with that, let me turn it over to David Kite, who will lead us through the presentation. If you want to ask questions, please put them into the Q&A or the chat. As I said, though, we'll respond and get back to everybody immediately after the presentation. So David, let me turn it over to you.
Thanks, Larry. And I'll just open it up and I'll pass it over to Dr. Zig. But yeah, feel free to interject with questions, either put them into the chat or just interrupt us as we go. We'll also take some time at the end to make sure that everybody's questions have been answered. But from there, I'll pass it over to Dave.
Yeah, thanks, Dave. Thanks all for joining. We'd like just to kind of open it up. It is a round table, so if you have questions as we go through, just chime in, or you can hold until the end, whatever you prefer. But we're flexible today and want to engage in conversation while we share all the information here from the survey. I'll just start as an introduction. So I'm Dave Zig. I'm board certified physician in family medicine and lifestyle medicine, but my career's been a bit different. I've been here in Colorado for a little over 25 years. Started out in hospital system leadership with the intent of trying to fix healthcare. I'm an entrepreneur at heart and am always looking for ways to do things better and find solutions. And the hospital system was a challenging environment, and I learned self-funded employer is where to go. And so I spent 10 years actually at Lockheed Martin on their corporate leadership team, did all things benefits, but one of the core strategies that we had during my 10 years there was building and managing the strategy and operations of our 28 on-site health centers. And around, 15 years ago, I reached out to the best, Dave Kite, who was at Mercer at the time, and worked with him very closely over those 10 years. We managed them ourselves, then eventually hired Premise to take them over. So I got to know Dave really well. I ended up at Mercer, actually, right after Lockheed Martin. I was a clinical services leader there, where I led the team of docs and nurses and other professionals, and worked with Dave very closely. I'll spare you all the little in-betweens in my career, but I've been at Alliant now about 2.5 years, and because I'm passionate about this topic, and you'll hear it as I go through the data here, I begged Dave to come over to Alliant, and so now he is here. And chances are, just hearing the names and the companies you all represent, you probably have worked with Dave if you're in the space of on-site, near-site health centers. He's the guru, as we call them. So Dave, let's move on to dig into some of the data. All right, so it's not surprising here to see that 54% of employers responding to the survey are looking to increase their services and or staff to their existing health centers. And another 28% are planning to add additional centers. As many of you know, our $4.9 trillion market here in the US has favored secondary and tertiary care for decades. And the US has historically underinvested in primary care. And this really has resulted in community primary care crumbling, especially in the last decade. And we see it in client data. I look at client data all week long, and we see it. It's just impacting the health of our population and costs. And I believe it's a root cause of why the healthcare system itself is broken. We know good primary care is foundational. I'm probably speaking to the choir here, but it's essential in managing a population's health effectively and keeping costs lower. And employers understand this and are taking additional action to improve and effectively manage the health of their members. So these numbers aren't surprising, and I expect when we see double-digit trends for the majority of us next year, we'll see even more more interest and more traction in growing their foundation of primary care. Also, 41% of respondents selected other, and I just want to call that out. Most of those who marked other noted that they are not planning any changes. So that's what that means. 6% of respondents are interested in shared clinics. We're seeing a lot more traction, especially in down market, so smaller employers, getting a lot of interest from smaller employers there, especially those with fixed budgets, like municipalities, cities, counties, that sort of thing. 3% suggest that they might close a health center. And what we've seen, just this dynamic economic swings that are happening in many different industries, it's not too surprising, actually, the 3%. On the next slide, we'll dig a little deeper into why employers have clinics. So when asked what they're working to solve, essentially, with their employer health centers, the answers reflected quality of care is number one, and experience is number two. And this we kind of put into our value equation when we're looking at a healthcare ecosystem. So with quality and cost of care being so variable in every market, I wasn't actually surprised to see quality as a key, especially knowing that, an on-site or near-site health center with a good primary care foundation where most referrals happen, we are seeing a lot of focus on steering using quality and cost data. So that's been, I think, seeing a lot more traction here over the last year or two. Access was number three, with the community primary care the way it is in largely fee-for-service world. Access is terrible. We probably all experienced it ourselves. So taking control over of this with better access with an employer-sponsored model makes a lot of sense, and it's good to see this as a priority. Productivity and managing plan costs were also at the top of the list, as well as recruitment and retention. OC Health metrics, including workplace injury management, was also a focus. On the next slide here, we'll look at the use of health clinics as a medical home. So when we look at the employer clinics as a medical home for members, and this indicates members accessing a holistic primary care model, typically wrapped with behavioral health and other services, for the majority of their care. We see that 29% responded that the majority of their employees, more than 50% of members, are using the clinics in this way, which again is not surprising given the climate of community primary care. 25% of respondents noted, though, that a good portion, but not the majority, about 21 to 40% of members were using the clinic as their medical home. And 16% responded that the question wasn't applicable. And this signifies that their model doesn't include the use of the clinics as a medical home. But we're seeing more and more interest in those with clinics, but not being used as a medical home, to move to a medical home model. Okay. And Dave, if you catch anything that I didn't cover that you wanted to highlight, let me know. But on the next slide, we'll look at OC Health. So a good portion of the respondents. Oh, yeah, thanks. A good portion of the respondents offer OC Health services, and it's not surprising given the size of the employers who responded. The number one service, with 71% of respondents selecting the option, was offering work comp support, treating work-related injuries and illnesses. I was surprised, though, if you look down the chart, that only 45% are doing full work comp case management, which is, in my opinion, in what I've seen in the industry and what we did at Lockheed Martin, a really good way to manage the cost of cases. So I think there's probably opportunity there to expand what they're doing. Keeping the management of work comp in-house can be very, very cost effective. This is followed by common OC Health services, including like drug and alcohol testing, physical exams, pre-employments, DOTs, see return to work support, fit for duties, things like that. And then 41% of respondents offer ergonomic programs and support. That was actually a little bit surprising to me, just anecdotally, but it's a great service to add additional value to the support that you have in on-site near sites. We did a lot of that work at Lockheed Martin in holistic ergonomic programs across the enterprise. So I'm going to hand it back to Dave to continue on some of the survey results. And again, feel free to chime in with questions or even experience as we go.
Thanks, Dave. And thanks everyone for joining today. Hope everyone had a nice holiday. So I'm going to walk through results from a number of topics and share some findings and some insights from my experience. As Dave alluded to, I've been in this industry for a while now, about 20 years. I lead employer health centers consulting practice here at Alliant. I've been here for about 2.5 years, and before that I was at Mercer for a little over 17 years. I'd say that for me and the different clients that I've worked with, I think worksite health centers are really a foundation for a health and well-being strategy, and it really kind of puts the stakeholders in a position to customize that solution to really fit their ecosystem and their specific objectives. But one of the most common mistakes that we see, and one of the reasons I'm excited about the survey, is that we see stakeholders really champion and build the business case to sell the initial concept of a clinic, and it's solving a specific problem or fitting the ecosystem at a specific point in time. And then they kind of walk away from it, and they don't actively manage it. And health centers really need to be kind of tweaked and adjusted as you go on an annual basis. And so that's where the survey data really comes in from my perspective, is keeping tabs and have it on what are the trends and developments in this space, and then benchmarking your own program to things that are happening to make sure that you're really optimizing the performance of your health center or health centers to kind of get the most value out of the program. So we'll go through a number of different topics in here and just kind of sharing kind of our perspective on that. The first one is a common pain point, and one that kind of comes to us for both clients as well as other employers that we don't work with yet, and that's around the topic of health savings accounts. As many of you know, due to IRS regulations, members enrolled in a high deductible health plan with an HSA are required to pay a fair market value. And so this topic becomes a pain point in creating barriers to people getting the care that they need. Specifically looking at the survey information, it's helpful to provide evidence as you are making difficult decisions, often in partnership with your legal team, either internally or externally, on making choices around what to charge and how to charge it, and making sure that that's all compliant. So the first major topic that we dive into is, how are other employers administering this? 69% are charging a single flat fee. It's what we see as the most common, that fits with what we hear and see anecdotally. And that's compared to other methods of doing this, whether it be a tiered fee schedule or a full fee schedule. It kind of depends on how conservative a particular employer is. 13% of employers choose not to charge at all. And we have had clients, as much as we have counseled them on what the regulations say, but they choose to make that choice and actually not charge at all. And then kind of the big question, which is often the most difficult to triangulate, is, what do you charge? So we asked another question on what they charge, if they charge a single flat fee. And we see a pretty wide range, which is not surprising given how gray the regulations are. And the range is anywhere from $10 if they're charging something, up to $65 on the high end, and about the average is around $35. So that decision is really an independent choice, but the survey information is really helpful in terms of having a data point to point to defend the decision.
So I am really curious, Dave. I want to pause on this really quick because $35 an average flat fee can be a barrier, especially when employees are paying more for their health insurance, and it's really eating into their income every year. And with the OBBB, the one big beautiful bill, right, and this new rule that says we can use tax-free dollars to pay for DPC. Now, an on-site sponsored clinic or near-site is different from a health plan standpoint, that sort of thing. But it just seems that the federal government is kind of releasing the reins a little bit on offering primary care services, even outside of preventive care. And I know I have never seen an employer actually audited or penalized for not charging. I'm just curious if we see a little more interest or traction in doing away with these fees. Maybe a little bit of risk, and we probably wouldn't consult on that. But any comments from anybody? Is anybody thinking about that, about removing that barrier?
Well, as you might be aware, NAWHC has been working with a collaborative of employers and health centers, as well as ERIC, the ERISA industry group, to change the legislation, because this is an IRS requirement that if a center offers more than first aid or triage to someone who has an HSA, they must pay a fair market fee. So it's a matter of changing the legislation. It's not an optional choice, clearly at all. So we are continually working on that. And again, we thought we were going to get something in the big, beautiful bill, but that didn't work out. So we're working toward that. We've been working on it for 3 years, and we're still confident that we will get access to changing the law. But right now, employers are still encouraged, as David said, to charge something. We also have not heard anybody who's ever been disciplined or penalized for not doing it, but we would never recommend you don't do it if you have HSA population.
Sure. I guess we're all rule followers, Larry. And thanks for chiming in. Yes. Waiting on the legislation. Danielle agrees. So thank you.
So the next topic, what services are employers offering? Again, kind of at the design phase level, this decision really starts with an employer's specific goals and objectives. And then that decision kind of is faced with kind of economies of scale and what makes sense given the size of the population, the demographics, different barriers that might be in place to offering a full scope of services. In general, I think we come from the perspective in our experience that the more services you offer, there's an exponential effect of creating foot traffic and exposure to core primary care services or other lines of services that might be available. So it can be advantageous to layer on services. One driver of the expansion of services from a trend perspective, I think, is understanding technology and how that's changed over the last 5 to 20 years. Through technologies, clinics are really able to do a lot more than they used to. Primarily, that's through expanded reach and being able to offer services through digital pathways, both video as well as asynchronous text. I think some of that is behind some of the trends that we're seeing, in addition to the kind of the populations that are behind the health centers themselves. One service category that continues to climb, we were kind of watching this during COVID, and we weren't exactly sure what post-COVID life would be for the on-site clinic industry. But behavioral health is really continued to take root. If we look at year over year performance, the last survey that was done was in 2023. Behavioral health was at 33% then. Now it's at 45%. And that service particularly we see is getting a lot of traction using a combination of on-site as well as virtual. It's one that translates very well. So we would expect that behavioral health is here to stay, not to mention its, as Dave alluded to, its role as part of a medical home best practice design. We also get a lot of questions around health management services being offered through the health center. 71% of employers offer biometric screenings and weight management services through their health center. This has been a consistent trend we've seen over the last 10 years plus. Using that as a gateway to create engagement and outreach, collect data, has been very effective. We are seeing a continued rise in health centers offering services that help employers with downstream utilization management as well as impacting total cost of care. This also aligns with that trend towards a medical home level model over the last couple decades. This includes services like care navigation, referral management, case management, all being offered either with dedicated roles on site as part of the care team or layering in virtual services that can work in coordination with on-site staff. If you look at the data trends, use of care coordination is up to 60% from just 37% in 2023. So a big jump there. So I think this trend will continue as employers really seek to unlock the opportunity to impact total cost of care through their health centers.
Hey, Dave, I want to call out just a couple of opportunities in this data. So one, care navigation at 50%. I think the data we have, I mentioned the quality and cost data, the data we have in quality and cost now is actually much better than it was 5 years ago. And seeing only 50% leverage their on-sites or near sites for care navigation, I think is a miss. I think there's an opportunity there to do a lot more with employers and using that data to navigate to high quality, high cost, even within whatever BUCA network you have. The other opportunity is around direct contracting at 8%. Again, direct contracting historically has been a challenge because it's difficult to get a hospital system or a hospital to speak the same language as an employer. And I've tried for many years, but that we're seeing this influx of third parties that offer kind of turnkey direct contracts that can be bolted right on to a foundation of primary care that an employer sponsors for, I'll call it alternative contracting for even bundled episodes that add additional value outside of a BUCA network. So there's a ton of opportunity, and I think we're going to see a lot of traction in those two areas here over the next couple of years.
Thanks, Dave. Staffing, another kind of critical choice. And in terms of what staff you choose to employ directly in the health center or even through virtual dedicated or shared pods. Nurse practitioners continues to be the most common provider with 76% offering that staffed role. There is a correlation between the size of the clinic and the prevalence of physicians. And there's also the ongoing dynamics of the shortages of physicians on a national basis. In general, smaller provider clinics tend to be nurse practitioner led for cost efficiencies, but we do see single provider clinics be launched with physicians for various reasons. We are seeing an increase in ancillary staff positions. This can obviously be dependent on the size of the populations that they serve, but in this data, 30% of health centers now staff a nutritionist or dietitian. That's up from 17% in 2023. There could be some dynamics of correlation with the access to virtual programs that are coupled with on-site. And so in the survey data, it's a little bit hard to tease some of that out. And we are seeing that as being a common model of layering in some of these other health management services using virtual staff positions that couple with on-site. So there may be some of that going on.
Hey, Dave, Rachel posted a question on care navigation. I don't know if you want to answer it, if we want to answer it now, or if we want to wait till the end. And
go for it.
So Okay, so just around care navigation, how does this differ from what the insurance companies offer? So insurance companies will offer care navigation, with a nurse model, that sort of thing. What we're talking about is actually using quality and cost data. So third parties like a Garner or Care Journey or one of the other ones, but there are differences in those models. But I'll just call out. So using that data and then having the clinicians and even the care coordinator in the clinic using that data to then refer a patient to a high quality, lower cost. As you know, the quality and cost is hugely variable in every market. You could go to an academic health center and get terrible quality and pay 3 times what you would pay with an independent orthopedic surgeon who's probably getting better outcomes and doing more appropriate surgeries outside of that academic health center. So leveraging that data at point of care would be one. Now, there are other ways too regarding outreach and that sort of thing. If you've got care coordinators, care managers built into your model, you can employ them with claims data to identify those who might be needing a surgery and then do outreach, that sort of thing. But really, that's kind of where we're focused. Now, we are seeing the BUCAs create models around quality and cost data. I've yet to see one that is really impressive, but Surest is one that's getting a lot of traction, and now all the other carriers are following suit with their own. We're also seeing quality and cost data being built into other navigation concierge platforms. We saw Quantum Health recently purchase whatever data set that is. I'm trying to remember. Why can't I not remember it? Anyways, so they just recently acquired a company that has pretty solid quality and cost data. So that really is what we're describing, is point of care for the most part.
Financial model. So this one is important, and I think in some cases not every employer's fully aware of the kind of the control that they have to pick the financial model and influence it. Many are, but there are cases where they're not. I think it's really important. It's foundational to the success of the health center in aligning the interests of the vendor, manager, providers with the employer sponsor. What we see in the data is that cost plus is the dominant model at 44%. But there are other models that are out there that exist for various reasons. The data point here that really surprises me is that 26% of respondents have a fee-for-service model. In that for years, just foundationally, health centers have been it's one of the top 5 reasons what they're trying to accomplish here is getting away from a fee-for-service financial structure as they're kind of seeking the triple or quadruple aim. Some of that might be teased out by the existence of models like One Medical that kind of bridge and have a membership plus a fee for service kind of component to it. So that might be part of what's going on there with that data point being as high as it is. But looking back at other past survey reports, that there has always been this kind of prevalence of the fee for service model, even in this industry. But it continues to surprise me. I think it's an important thing to consider as you kind of, again, on an annual basis, kind of tweak the strategy and consider how do we optimize this to reach its peak performance. Incentives. This one obviously is very important to understand because I think there's a lot of different ways that you can incentivize individuals, both employees as well as dependents, to engage with the health center. And each group might have different ways that are the most effective. We asked in the survey, what incentives do you use to encourage employees to visit the clinic? The most common response is eliminating or reducing copays, and that is consistent with kind of what we hear anecdotally. The most or more aggressive approaches include reductions in employee premiums at 6%, or offering the health center as a plan option 8%. Again, that the prevalence of those incentive models have been around. It's been around in the last 10 years and has kind of been in that ballpark. I'm kind of surprised that it hasn't grown about to be somewhere higher than that. Because getting people to engage in this model, while the people that do really find this, it's often that they're the most popular benefit and they love it. Um, you know, Getting them to use this as their medical home is a kind of key driver towards impacting total cost of care at the population level. So um, I think I'm optimistic that that might change in the future. Technology, I mentioned this before, and there's different layers of this as we kind of have been tracking and understanding the technology platforms that serve these health centers and the vendors that operate them in the industry. I think looking at the top row, I'd say the long-term trend of employers adopting EMRs, I can declare is over. Now at 97%. Going back to date myself, 20 years ago, it was in the single digits. We were in the early days, so things have changed a lot. Now I think we're really trying to focus on features and functionality and really understand how these technology platforms and systems work to achieve the goals of the employers that sponsor them. I'd say probably the fastest growing component of this information is around mobile phone applications. That's up to 60% from 43% in 2023. Probably it's surprising that it's not higher than 60%, frankly, given how people live on their phones. I think kind of on the flip side, patient portals had been popular, and I think mobile phone applications are kind of catching up. And I think vendors and their technology partners have been evolving their mobile phone application capabilities. But I also, as we think about that, and as you're evaluating how you optimize the performance of that application, or if you're thinking about different technology partners to serve for or support the health center, it's really important to dive into the patient experience and understanding how they use the mobile phone, and then how that mobile phone is integrating with the care team or the broader health center. It's often an overlooked component in terms of its importance, and we're seeing continued increase in focus on that going forward. And diving a little bit deeper into this, and probably not nearly as deep enough, but we asked which of the following technology services are available to patients. Online appointment scheduling is clearly the most popular, and that's for good reasons. Solving for primary care access is usually a core objective for employers that sponsor health centers, and having a functioning tool for scheduling appointments is important to get people through the door. It's important for the efficiency of the health center itself, and how it's an extension to the care team and removes the responsibility of scheduling appointments from people picking up the phone. Although we most commonly will see that as a supplementary way to schedule an appointment. But that's followed by different ways to engage with the care team. Telehealth at 75%, secure emails 60%. Texting is one that's growing quickly. That's at 32%, but that's up from just 10% in 2023. I think the vendor partners that we work with are finding out how much people love to text, and how easy it is a way to communicate with the care team. And so we'll continue to see rapid adoption of that. And as we've kind of monitoring the evolution of platforms like Epic and others in their ability to support texting as a modality. Just a couple more here. Shared clinics. This is also another major trend that we've been watching for 10, 15 years, and the growing prevalence of shared employer clinics. Increasingly, employers are really considering this as an option to offer a similar level of benefit to the traditional on-site clinic. Survey results show that 25% of respondents participate in a shared clinic today. And there's really two ways to offer a shared clinic that, in terms of the most common approaches that we see. One is that it could be multiple employers that have on-site clinics and create reciprocal access, either in a geography or with a particular vendor partner that manages the health centers for them, or a common approach where the health center is built by a vendor who invests the capital to create the facility, and then they approach multiple employers to provide access to that individual location. Often, if there's in one geography, they open up multiple clinics. So that's the two most common approaches, but there's many different flavors about how you can get to that state of sharing access amongst multiple employers. So kind of it depends on the situation. In the survey, we asked, have you shared if you've shared a model, how much do you pay, or how do you pay for services? The most common approach is, and probably the easiest, is a PMPM capitated. Although some responded that they have a fee for service model. Again, that could be something along the lines of like the One Medical model. But the data reflects that there's just a number of different ways to do this, depending on the needs of the employers that they serve. Then virtually included this one, and if you haven't read the full report, I do encourage you to download it if you don't have it. We can send you the copy of it and read the full report. But there's other topics that we haven't covered. We're not going to cover here today. Virtual care is important in that virtual accesses to services really become a common modality to engage with modern clinics. It's a way to extend the reach of the care team, expand access, improve convenience, really support continuity of care. Virtual also offers the ability to add services I alluded to before that might not make sense for smaller clinics. So we're trying to get our hands around what services are being offered, and because I think employers are learning that they can layer things in to meet the need and provide that ancillary service foot traffic. We asked what virtual telehealth services are available. Most offer telephonic. It's almost just as an extension of business hours or accessing your care team on site. But I think the focus is really on access via to virtual video to the care team. Sometimes could be viewed as unnecessary, but if you can't get there in person, it does create help extend the kind of that connection to the on-site provider, when that kind of trusted relationship, which is so critically important. And we do see that in many vendors have developed separate pods of providers who will supplement the on-site team. So if you're engaging virtually, you might not be with the on-site team if they're not available, but you can access this pod of providers. Just under half of employers, from a service line perspective, offer behavioral health, disease management, lifestyle management, all through virtual. So easy to scale that stuff in and create an ongoing longitudinal relationship with the provider. And then the last topic we're going to cover in the data, and we'll open it up for questions, is around ROI. We asked, what was your reported ROI in the last reporting period? As many of you can appreciate, this is difficult in that employers often have different methodologies for how they measure ROI, but still really important to get a perspective of what other employers have achieved. 94% of employers reported greater than 1-to-1 ROI. 52% report greater than 2-to-1, and actually 25% report greater than 3-to-1, which are good results. From my experience in auditing and ROI measurement, I'd say the my point of view is that a properly staffed and utilized clinic should be break even on medical cost alone. It's really clinics that are under 1-to-1 are often have staff that are not at capacity or not offering the right scope of services. But ROI is a difficult topic, and I'm happy to answer questions about that. So with that, I will we'll stop here and we'll open it up to other questions that may not have been asked while we went along. I know Larry had to step away, but he did want us to just go through and call on each individual just to make sure that their questions had been answered. So I'm just going to go through my list and quickly call on you. And please let us know your feedback and any questions that you have. In no particular order, Mark Fisher.
Yeah, that was great content of particular interest. I thought your ongoing conversation around how do we handle the HDHP conflict is an interesting. So I don't know that any of us have any answers there. I'd be curious if anybody else has commentary on that. And then, of course, Dave, you and I have talked about shared clinics, and so how do we end up pricing participation in a shared clinic? Those are ongoing questions that I have. But other than that, the data was excellent. It's good to see that larger organizations are utilizing this clinic model, and there's a lot to learn.
Thanks, Mark. Tom at Pfizer.
No, great information. I think the comment about the care navigation at 50% is a missed opportunity by Dave was spot on. No questions. How do we access the full report?
We will make sure that a copy of the report gets sent out to all participants here if you haven't received it already.
Perfect. Thank you, David.
Yep. Tracy?
I have no questions. I thought it was very good as well. Thank you.
Thanks. Rachel?
Yes, I had a question about ROI. Our clinic offers a lot of lifestyle management, preventive health management services. And I was wondering if anyone has any recommended methods for accounting for that in your ROI calculation, since some of the benefits are, of course, going to be down the road in people's health journey.
Yeah, I think in the clinic industry, I think in the studies that I've seen, it's less common to isolate the lifestyle or disease management services specifically. Most methodologies try to focus on attribution or just general user, non-user cohort analysis using risk adjustment or more of a longitudinal statistical approach. But I think it would be reasonable to, if you're trying to isolate the performance of those service lines, to isolate those cohorts and use kind of the same approach. I just haven't seen it done as commonly.
Yeah, if they've been in place for a while, Rachel, you could do a retrospective matched cohort analysis, and as Dave said, kind of focusing on those cohorts, and just look at disease management. I mean, being lifestyle medicine boarded, I'm pretty passionate about that strategy. And if you're getting engagement and you've got it over time, it would be very interesting to take a look at it, because I'm sure there is an ROI around that.
Thank you.
Michelle Storbagen?
Yes, thank you, David. So I don't really have any comments. I think it was great data. I was just going to offer that our parent company recently went to the plan option this year, moving to adopting a quad med plan. We created one because we now have, quad med everywhere, which is, 50 state primary care. So we were able to offer reduced or no copays for our core plan if you say that you'll get the majority of your primary care from Quad Med. And so that went into place in January, and we've been kind of closely studying it. One thought was, that all the people that already use Quad Med would just sign up for that plan. And of course they did, but we're also seeing about 20 to 25% of new growth in PCP adoption. So that has been an effective plan for us. We're still trying to get the word out to our remote population, just about half of our population, that they can sign up for the Quad plan if they're not by a health center. We're still struggling with getting that message out there, but it's year one. But I strongly endorse that one. I think that that's a good way to, from someone that's had health centers for a long time, kind of continue to move the needle. So, but I saw that was only 8%. So,
Yeah, great feedback and good data to support the opportunity there.
That's great, Michelle. Look forward to hearing how that goes forward.
yeah, absolutely.
Oh, Larry's back. Danielle?
Thank you for the information. I thought it was really good. I was encouraged that there's so many people using the centers for workers' comp. And I think it's definitely an area that our area can use to grow as well.
Hey, Danielle, can I ask you a question just regarding the recent Indiana legislation requiring the nonprofit hospitals to do direct contracting? Are you seeing, is Indiana University doing anything in that, taking advantage of that new legislation?
I'm not sure that it will do much.
Yeah.
We haven't had much luck just getting any kind of negotiations with any of the hospital systems. So, yeah.
I think
Why do you
everybody's
think
still
that
kind of
is? Why do
whirling.
you think that is?
Personally, I think that there's quite a bit of monopoly. So there's just no market pressure for them to negotiate.
Interesting.
Thanks, Danielle.
Now, that might change if the government starts enforcing the legislation. It'll be interesting to see how the hospitals spend now. There's a lot of opportunity for employers there.
Amber.
No additional questions, but really good information. Thank you.
Thanks, Amber. Melanie?
Thank you for the information. I found it really helpful. I think one thing that I find really, I really appreciate about these presentations is it validates, I think, where all of us are. Like nobody seems to have the answers, right? Like we're all kind of navigating this together and facing a lot of headwinds from the traditional healthcare system. And so I just really appreciate everybody having the time to come together and at least continue to support this, because that's what it's going to take to change anything. And from a personal standpoint, we're kind of just waiting. I think it was Rachel that said, we're just waiting for the legislation. Like, what does primary care actually mean? Direct primary care, what's the definition? So we can start expanding our services and not fear some kind of potential retribution. So thank you.
Good points. Thank you. Tracy.
I'm good, thank you.
Thanks. And then Jeff?
Yeah, no questions for me. Great information. Really appreciated the dialogue on the interaction of on-site clinics with high deductible health plans. And Larry, really appreciate your group's advocacy on that regard. I agree. It's an area that is a miss, and one that kind of, consistently I keep waiting for the legislation to catch up with these things. So that was all very good.
Thanks, Jeff. Michaela.
Hi. I thought the information was incredibly interesting. The data was interesting as well, but I do not have any additional questions. Thank you.
Thanks, Michaela. And Francis?
Can't
Maybe
hear
on mute.
Francis. Yeah, he was off mute, but or she was off mute, but
Yeah, some audio problems.
yeah.
And then Cindy Joe. May not be there anymore. Did we miss anybody? Any final questions, comments?
Well, if not, thanks very much, Dave and David, for the presentation and the great material. As I said, this has been recorded, and a copy of the link and a copy of the report, the full report, is available for NAWHC members and anybody else who's interested, who's registered for this as activity today. We hope to use this as in our future programming, as well as to help people compare and contrast what they're doing. And hopefully this helps you gain a leg up on understanding how you compare and what you can do to increase the value of your center. So thanks, everyone. Again, have a good holiday season. David, we appreciate your time and efforts. Everyone, take
Thanks
care.
for having us,
Bye-bye.
Larry.